The Centre presents a new podcast, CBME and You, a podcast devoted to promoting awareness and debate around controversial ethical issues in biomedicine.
Hello and welcome to CBME and You, a podcast by the Center for Biomedical Ethics. Today's topic, palliative care. What is it? What ethical challenges do practitioners face? And joining us today is Dr. Neo Han Yee, Head and Senior Consultant of the Department of Palliative Care at Tan Tock Seng Hospital. Welcome, Han Yee.
Hi, good morning, everyone. Thanks for inviting me over.
It is our absolute pleasure to have you on the pod today. I have some questions to get to know you a little bit better. First question, coffee or copy?
I've gone beyond that.
He's transcended caffeine.
Yeah, it used to be coffee, and then after that it went to kopi, a convenience, right, 3-in-1. And it has gone to Yuan Yang. I don't know whether you have tried this local drink whereby you mix tea and coffee together. It's super potent in caffeine. It keeps you up the whole morning.
Is that Hong Kong?
Yes, it's probably from Hong Kong.
Okay.
Yeah, but it's widely available in Singapore as well.
Okay.
Yeah, that's right. So it's a convenient caffeine booster.
You're a doctor, all right?
Yeah, all the more I need that concentration.
Oh, thank you. Second question, what country would you like to travel to the most next?
I would want to go to Sri Lanka. Yeah, I haven't been there before, but it's got a very rich heritage, and I've always wanted to visit some of the temples and the paintings over there and the wall paintings and all that. So never had a chance to. So one of these days, yeah.
Good luck.
Yeah, thanks. Yeah.
And last question, what's your go-to karaoke song?
This brings back some stories when I was 5 years old and I was sitting in that pre-primary class or kindergarten, and the music teacher was asking me to sing Do Re Mi Fa So, and she hit me at Do Re Mi Fa, and she said, "Sit down." Thereafter, I'm no longer a music person. It's PTSD from henceforth.
So you've never done karaoke since?
I didn't enjoy karaoke, so it's one of those things that I would avoid at all costs.
I love how different guests have found different ways of saying, yeah, I hate karaoke. I'm never going to do it.
Absolutely not. Thank you.
Sure. Mm-hmm.
All right, let's get to some serious questions. The first question is kind of a definitional one. So when compared to other forms of medical care, what makes palliative care distinctive?
Yeah, so you would imagine that in medicine we deal with human diseases and death, right? But in truth, many a times as doctors, we're thinking more of the disease than the person. We'll be thinking of the drugs, the surgery, the intervention, the stents, the procedures, and we forget the person behind the illness. So in palliative care, by nature of the fact that we see dying almost on a daily basis, right? There's a greater need for this human connectedness. Because that is where the intrinsic suffering exists, right? We are trying to deal with existential suffering about the identity that we are losing as we, loses our function, loses our comfort, loses what we take for granted every day. So palliative care is distinctive in the sense that there is a vital need to maintain human connectedness, both to the patient, to the family, and inwardly towards yourself. You have to be comfortable with seeing dying. Right? Of course, there's a very unconventional way of defining palliative care. Right? Palliative care, if you want the factual, scientific, or consensus statement, would be that it is, a start of a holistic approach to care for all patients diagnosed with an advanced illness, cancer or non-cancer, who needs, some form of relief in terms of suffering that encompasses physical, psychological, spiritual, or functional domains of life.
So does that mean that in the face of existential suffering, the best answer is just simply human connection?
Well, I think existential suffering actually refers to something that's very deep-seated, right? It's almost like your personhood fracturing towards the end of life. So give me a little bit of time to elaborate. You might want to take this off as it takes too much time later on.
No, please.
No, I love this philosophical.
But it goes straight to that question, right, of existence. We take for granted many things in life. You can poo normally now. You can go to the urine pot, very easily. You can go to a supermarket. You can engage with friends and family. You can talk. You can eat through your mouth. But when you're struck with a serious illness, many of these get robbed away. You may need to be fed via a tube. You may need something that goes into your private part to pee. You may need help to go to the bathroom to poo. And almost definitely, as the body weakens, you lose many important roles in life. You may not be able to function as a father or a mother or a nurturing grandmother or a very productive employee if you so pride yourself to be someone of that nature. The fact is that the identity that you created over decades, that personhood fractures when death comes closer. That is existential distress. So that's why in palliative care, we confront this existential suffering on a daily basis that our patients and their family members go through. Family members too, because their loved ones who are dying forms an integral component of their own identity and personhood. So when a loved one is dying or have died, it leaves a vacuum within their own personhood that's never filled. So that's why if you go online, people would say that you don't tell a grieving person that time will heal. Because if you truly love this person, that wound will never heal. It will always be a fracture and a hole in your personhood that you grow to live around. I don't know whether I answered that question.
That was amazing. That's incredible.
I'm just like, whoa, man.
Yeah, I'm just like, do palliative care physicians make the best philosophers?
We think a lot. We reflect a lot.
Yeah. So quick follow-up question for me.
Sure.
So how then do you deal with it? So if you are aware of that there is no answer to existential distress, then how do you palliate patients?
Yeah, so in existential distress, we must first think about what constitutes our personhood, isn't it? Because what we are trying to do in palliative care is to try to return a person to some sense of normalcy, be it psychologically or physically. So what constitutes personhood? It's constituted by physical elements, like, for example, our appearances. That formulates part of our perception of dignity. It refers to the feelings that we experience, feelings in terms of pleasant things that we see, nice music that we hear, sensations, tactile sensations that are pleasant or at least not uncomfortable, right? It also refers to our ability to think and process information, our way in which we cope with crises, and basic awareness. And in diseases and death, all this comes down. Your appearances change. You may have a tube in various orifices of your body. Your feelings change because your sensation may become very unpleasant. The daily experiences become more unpleasant than pleasant, right? Your perception of who you are change. Right? Your perception of your ability to function as a mother or father also change, right? Your coping mechanism also will change, right? And many times it becomes maladaptive. So to then, as a palliative care physician, handle existential distress in our patients, what we do is that we cradle our patient's personhood and hold it together. Where there is physical suffering, we use medications or non-medicational methods, non-pharmacological methods to relieve physical distress and suffering. When they encounter unpleasant sights or smell, we try to change the environment. If there's a nasty wound, we try to dress it up. We use medications or tea bags or coal, whatever, charcoal, to take away that smell, so that it returns normalcy to a person's five senses, right? When a person is unable to fulfill their role that's important to them in their dignity and personhood, we help them fulfill that role. For example, for a father or mother that's dying, we try to do legacy work with them to help them fulfill their role by leaving behind perhaps teachings or instructions on a yearly basis on a birthday card to their child, because they will never see them grow up, right? And if the issue lies with, for example, death anxiety that threatens that very sense of awareness of the world, that's something very much deeper, and we have to delve deeper into it. But I think that would be a story for another day. Yeah. So, for palliative care physicians, well, you can say that we deal with physical suffering a lot. We use a lot of analgesia, some bits of sedatives if needed. But in truth, it goes beyond just pain. It deals with suffering, and suffering is all-encompassing.
Yeah, I really like the way you've described palliative care. I think it's almost like a really beautiful conception of medicine, medicine that's focused on the person in a way that's like the person qua person, as opposed to a person as a biological creature. And so one follow-up question I have is maybe all medicine should be like this to some extent. And as a palliative care physician, you're probably like, medicine has a lot to learn from palliative care. So maybe the distinction isn't so quite distinct anymore if you take into account.
Doctors, like all people, have got different personality affiliations. If you ask any random doctor in the hospital to see death in the face every day, not everyone would be able to accept that kind of life on a long-term basis, right? If you want a particular nurse or a social worker or any healthcare professional, allied healthcare professional, to deal with very raw emotions from families or to reconciliate your own mortality as you see your patients die, I don't think it's the cup of tea for everyone. Right? There are intrinsic factors, there are extrinsic factors. Intrinsic factors may be perhaps your own faith-based system, your non-religious spiritual practices, your own values in life, your own philosophy. But extrinsic thing may be, for example, your setup of your own family. Your family, there might be someone that's unwell at home, and that stops you from engaging distressed patients and family members in a very humanistic and emotive manner. So I would say palliative care is definitely not the cup of tea for everyone. But I will also say that all doctors should have some fundamental knowledge of palliative care. Palliative care is not just about morphine or fentanyl or sedatives, because it is an approach, like what WHO has defined it to be. An approach can encompass everything from pharmacological to non-pharmacological treatment. So if you diagnose a patient with an advanced illness, you treat pain with simple analgesics, you refer the patient to a social worker for family issues and financial burden, psychosocial distress. That's also palliative care. If you see an elderly in a home care environment, you take care of a patient's advanced dementia, and the patient passes away very comfortably without much need of advanced therapeutics, that's palliative care as well. Palliative care, as I mentioned, is that human connectedness, the ability to tailor therapeutics towards the patient and family in a holistic manner that brings together people, that comforts people. That's palliative care. So that can be adopted by all disciplines. But there will always be a specialty need, because there will always be patients with very complex pain that requires sophisticated intervention, that you need more training over more number of years. You need a group of people that's got specialists, to see more of these complicated cases more frequently to accrue that skill set. Right? So there will always be a need for a specialty, but there will always be a greater need for generalist palliative care physicians, people who adopt palliative care practices in their own disciplines.
Even if you take dying out of the picture, I can see how the lessons of palliative care can make a difference. For example, if I'm facing some kind of disease or something that will cause me to be disabled or lose some kind of capability, that is the kind of thing that can affect my sense of self.
Yes, absolutely. So I'll give you an example. So for a couple of years, we were very interested in patients with chronic breathlessness. So these patients may have lung failure or heart failure. Many of them are cigarette smokers, and I'm glad it's on a decline. But I heard there's a increased tendency in the young picking up cigarette smoking again and vaping. So anyway, this group of breathless patients, as their lung and heart starts to fail, they turn breathless with exertion. So it may start off with feeling breathless, walking from one bus stop to the other. It may then progress to, I can't move from my bed to the bathroom. It may progress further to the point that I'm breathless because I can't swallow. Because every time we swallow, we hold our breath. If not, we would choke. So some of our very breathless patients have difficulty finishing a meal because they just can't hold their breath over successive mouthfuls of food. So this group of patients, from the point of diagnosis of lung failure or heart failure, they can live for years, right? And palliative care is not only for patients who are imminently dying. The same approach can be brought to patients with chronic breathlessness. And what we do in our hospital is that we collaborated with a few partners and received funding from Lien Foundation, right? And we created a breathlessness ecosystem whereby we united palliative care physicians, rehab physicians, cardiologists, and pulmonologists, lung doctors. And we created a service called palliative rehabilitation, whereby rehab services run concurrently and alongside palliative care. So palliative care is in charge of relieving the physical discomfort. The rehab side of the house, exercise their muscles and endurance to make sure they can preserve their function and their independence as far as possible. Teach them techniques to cope with activities of daily living so that they don't have to spend so much energy and get breathless. And this help keeps our patients feel meaningful and alive. If not, they'll feel so meaningless. They'll tell you literally that I don't want to live anymore. There's no need for me to move on. I'm not contributing to my family. I'm a burden. I'm losing every part of me that I once loved, that I took for granted. But now I can't find the will to live anymore. But paradoxically, this group of patients are the group of patients that are most fearful of dying. For the breathless group of patients, they are highly anxious. You just imagine when you're very sick, you're like drowning in a pool of secretions. You're hunger, there's air hunger on the ground, right, on land, right? And these group of patients do not want to die because when they die, they associate dying with being breathless and anxious, asphyxiation and drowning. So these group of patients have a lot of fear. Yeah.
Wow. I feel like my perceptions of palliative care have been really wrong up until this conversation. And I just think you have been so eloquent with the way you've explained it that it's been quite enlightening.
Oh, thank you
for me
very
to
much.
understand. So thank you. You just touched on that concept though, that for some patients dealing with chronic illnesses, terminal illnesses, they do not want to live. They would like to die. And so this brings me to the sensitive discussion of assisted dying or euthanasia, depending on the legal system we're dealing with. And so I wanted to ask the difference between palliative care and assisted dying, particularly when we're dealing with patients who might refuse with life-sustaining treatment or artificial hydration and nutrition. And what are the differences between all of these practices? Because to the outsider, sometimes they can look quite similar.
Yeah. So I teach this to my residents quite a lot. So there are actually three entities that we are trying to differentiate. One is murder. Second is medically assisted dying, right? The third is actually withdrawal of non-beneficial unwanted treatment, right? And the third one may involve palliative care, but not necessarily so. As we mentioned, palliative care encompasses treatment beyond the imminently dying, right? So let me give an example of murder to the public, right? I belong to that generation many years ago, but this story is still very vivid. People at my age will remember the Coven double murder, right? In Singapore, this would be sensational, but maybe in another country it will be, non-sensational news. So there was a double murder that happened in Coven, whereby a police sergeant tried to con an old man of his money, and the old man saw through the ruse, right? So the police sergeant stabbed the old man to death, and on his way out, he saw the son coming back, and he drove his vehicle into the son and killed his son as well. So the body was dragged over quite a distance, and therefore it was so sensational. So this is murder, right? There is an intention to kill. There's a motive to kill. There's the act of killing, right? Stabbing a person or jamming a vehicle into a person. The person died as a result, right? And, in US, they will differentiate again whether you are actually feeling happy after you killing the person, right? So this fulfills that criteria legalistically for murder. Intention, motive, act, death, right? And that whole temporal causality, right? That's murder. What about euthanasia or physician-assisted suicide? So in euthanasia, you inject a lethal dose of medication into a person's system and the person dies, right? The person that carries this out is usually a healthcare professional. There's an intention to shorten life. The motive may be colored by the fact that we want the patient to be comfortable and be free from suffering, but intention remains that you want to shorten life to a point that's earlier than what the natural cause of disease would be. The person dies as a result of that lethal injection, right? And therefore, in Singapore's context, legalistically, all these components fulfill the same components in murder, right? Physician-assisted suicide is a slightly different entity. Here, and it's not available in Singapore, right? Okay, so here the doctor prescribes a medication. The family member or the patient goes to a pharmacy, gets the drug, and then administer the medication to the dying person, right? Or to the very sick person, and the patient dies as a result. Here, the physician is a indirect participant. He provides the prescription, but the actual direct act of buying the drug, administering the drug, is actually the family member of the patient himself, right? In this case, it's more akin to perhaps abetment of suicide in Singapore's law. You're helping a person commit suicide, which remains illegal in Singapore, right? And then there's that last entity that I mentioned, which is the withdrawal of non-beneficial or futile care. So in ICU setting, we may have patients that we have tried for a long while to get the person's physiological system back to shape again and to wean off organ support. But in about a third or a quarter of cases, we fail, right? Despite the best effort, the patient we know would certainly die. And these mechanical ventilators, these vasopressors will only add on to the discomfort and prolong the dying process without added benefit and perhaps adding on to suffering for the patient and family. So in these situations, when a physician withdraws life-sustaining treatment, it is to allow the natural disorder, the natural disease to progress. And what eventually kills the patient is the disease itself, because the organs couldn't function. The organs needed those life support machines. And because these life support machines can no longer serve its purpose of curing the patient, and therefore we withdraw it to allow the natural disease to progress. And therefore, there is no human participant causing the act of dying, and therefore it's totally different. So there are these different entities. So pardon me for that long discourse. I thought
it
it's
needs
important.
to be very explicit.
Right.
Even then, are there a few cases which fall within really complicated gray areas where it's not clear whether it counts as assisting somebody's suicide versus allowing the natural course of a person's life to take effect? For example, so you mentioned something like withdrawing some kind of respiratory support as an example of allowing the natural course of events to happen. But of course, if a parent decided to stop feeding their child, that would clearly look like a form of murder. So, but it's not clear when we compare failing to feed somebody versus failing to help somebody breathe. What exactly the difference is between these things.
So just to define this question a little bit better, to scope it in more clearly. Of course, if this is a patient, if this is not a patient, there's no disease at all, and this parent decided to not feed this child, when the child was healthy, then that's neglect. The child dies of malnutrition or some other disorder, that's neglect, right? But if this is a patient who has got an advanced illness, right, and the patient is unable to swallow food, to swallow water, and that's quite common in patients in advanced stages of illness. The swallowing mechanism fails, right? And then the consideration is, should I sustain life by providing artificial nutrition, either by a tube into the nose or perhaps by tubes into the veins to supply hydration, right? So that's the question that perhaps we are talking about today, the continuation or initiation of artificial nutrition and hydration. Now, this is how the physicians and the court tends to look at it. Artificial nutrition and hydration are administered via tubes, by injections, right? They are not natural food and water. For example, the milk, I say this in philosophies, right, that we put into our feeding tubes, they are not milk from a mammal, right? It's a concoction of chemicals put together, put through a tube and into the body. How is that different from antibiotics that we inject up a vein, right? So these are non-natural products that the doctors use artificially to sustain life. Similarly, if we are putting an IV drip with sugar, with normal saline, with water, it's still a concoction of various chemicals that's artificially delivered into a biological system, right? So we do not, perceive artificial nutrition and hydration as on the same platform as, your bak kut teh, your mee siam, it's a different thing, right? So similarly, as you would, withdraw a mechanical ventilator in a patient who will no longer benefit from it, it becomes ethically permissible and legally permissible to withdraw a mechanical ventilator from a patient, and therefore it is legally permissible for us to withdraw some of these life-sustaining fluids and nutrition, right? And I would go on to elaborate further that sometimes these fluids and artificial nutrition may not prolong life, and in fact may add on to the burden of living. So many times in dying patients, when they are really close to dying, the systems are failing, the kidneys are failing, and they can't pass out much water from the urine, right? If you were to continuously push fluid into the body will swell. There'll be swelling over the legs, the limbs, the face. The extra fluid will create a lot more saliva. And like I mentioned, patients can't swallow, and all this saliva will make them choke. If they have a pneumonia, which is common at the end of life, the mucous gland will produce copious amount of secretions that a drowsy patient would not be able to cough out. And you end up having all this saliva and secretions trapped in your airway, stuck in between, your vocal cord. You can't swallow them in, you can't cough them out. It's like literally drowning on land. Right? Is that the way that we would want any loved ones or ourselves to go? So in this situation whereby artificial nutrition and hydration does not prolong life, does not lead to a beneficial endpoint, and may in fact lead on to a greater burden of living, it's perfectly ethically permissible, and legally permissible to withdraw in the patient's best interest.
Having said all that, though, for anyone who's ever seen the Double Down burger, there's nothing natural or permissible about it. So I would argue that there are some foods that are both unnatural and impermissible.
Okay.
Foods that we do eat.
I don't know how to respond to that.
I don't know if there's any good response.
I was going to ask, from my understanding of the Australian criminal law, there's an exemption to contributing to the death of another in good faith in palliative care. And so you can prescribe and provide a dosage of painkillers or a dosage of drugs that is meant to alleviate pain, knowing or foreseeing that it is likely the patient will die as a result. And so the Australian criminal law protects medical practitioners using the doctrine of double effect. You're not intending to kill them, you're intending to alleviate pain, and this is the only amount of dosage that could alleviate the pain. There are other qualifications, like it has to be in good faith, you can't overprescribe more than necessary. And I was wondering if there is a similar situation in Singapore when patients get to this point where they cannot breathe and just sustaining their life, or if you withdraw the artificial hydration, it'll take 12 hours to die in pain naturally. So do you have an equivalent here?
Right. So actually, just to reassure everyone, if you have a palliative care physician or a doctor that's trained in palliative care, 99.9% of the time, you will die comfortably, right? Yeah. So with advancement in palliative care, with the different opioids, medications for secretions at our disposal, the vast majority of patients under palliative care die comfortably, right? What happens usually in the dying process is that you imagine all the organs shutting down, the toxic metabolites that usually we would excrete out of the body by our liver and kidney can't come out because these organs fail. These metabolites travel to the brain shuts down. And it's a common thing that our patients will go to a very deep stupor, right? Prior to that, there might be a period of confusion and agitation that as doctors will try to keep our patients calm. But if you allow the disease to progress, the vast majority of our patients go into stupor and drowsiness. And from there, they just fade into the sunset and to their next life, wherever their life brings them to, right? So the vast majority of the time, you just need maybe a little bit of medications, if at all, to pass away very comfortably. Right? There are also a minority of cases, a very small percentage of cases whereby symptoms remains very intractable, very severe towards the end of life. And despite using the strongest dose of analgesia, we can't keep the pain and breathlessness under control. Oftentimes when this happens, there's an element of psychological distress. Because unfinished businesses, we just can't give up, we just haven't let it go yet, right? And this distress keeps the patient both aware as well as in a very agitated and distressed state. So in this situation, we would initiate a procedure called palliative sedation. But I must say this is in a minority of cases, right? So in palliative sedation, we do not use morphine per se. We already tried the opioids and it didn't work, right? And this is when we have to purposely make a person sleepy. We purposely make our patient's consciousness sink into drowsiness, right? So that the person may remain drowsy and unaware of that pain until their time comes, right? But even when we initiate this procedure called palliative sedation, there are steps to ensure that we are not intentionally causing a patient to die, right? A lot falls, of course, on the intention of the physician. The physician needs to be very clear. I'm giving this sedative because there are no other ways I can control this suffering, right? My intention is to use the minimal dose to achieve symptom relief. And once that dose is achieved, I will not escalate it, right? Of course, you need to do it fast enough in certain cases. If not, you lose that window of opportunity and a patient truly dies in distress. Right? So there's a bit of skill and expertise involved, right? But the evidence is that even when we initiate this kind of deep continuous sedation, it does not contribute to a hastening of that dying process. If you do it in a controlled environment with a specialist on board, it shouldn't contribute to that, right? So in Singapore, truly, we haven't found a need for that at the moment. Yeah.
That was a really good explanation of intention and how it does really matter, because the intention shows your humanity.
Yes.
It shows that you care,
That's
you
right,
tried.
yeah.
And that way, when it doesn't work out, which is often the case in medicine, medicine is not an exact science.
Yes. Yeah.
The patients are not maybe not angry, or maybe not as angry as they might have been, and that can bring some relief.
Yeah. That's right.
That's a really, really good explanation. I was wondering if we could talk about the role of families in palliative care,
Right.
and how many different family members may want different outcomes.
Right.
And so some family members may sometimes be happy to let the patient go, reduce their suffering by potentially sedating them earlier. Whereas some patients may be of the view that you need to let them die naturally, or you need to see if a miracle happens.
Yes.
And how you deal with all of these conflicting family values, particularly if you're aware of what the patient wanted for themselves.
Right. Yeah. So in palliative care, we are the strong advocate for patient autonomy, right? First and foremost, when a doctor comes into contact with a patient, a therapeutic contract is invisibly drawn. We are responsible to this patient. Our primary accountability lies with the patient's best interest and not what the family would want. So if the patient has expressed clearly what he would want, we'll try to keep by that, as part of that therapeutic contract, unless what he wants is something that is unreasonable or inappropriate. For example, a patient may demand that I want to be on life support forever, but we find that this is not going to work out. It will cause more suffering. In which case, then, while you may have that wish, the doctor are not ethically or legally obliged to keep to that promise. There's no promise in the first place. Right? It is a unilateral request that we would not accede to. Right? There are different manners to die. Different people might want it in different manners. Right? Some patients want to be deeply sedated for days to weeks so that they don't have to confront their suffering, right? But true, honestly, my own personal view to this is that there is much to be learned in that dying process, both for the physician, the family, and the patient, right? Why do I say so? It's deeply philosophical. I usually don't talk about this because it's a little bit contentious, right? Yeah. The truth is that before the advancement of ICUs in the 1950s, right? Before the advancement of life support, dialysis machines, people would die very much in their own homes with family members around them without all these artificial interventions. And people would accept that that is the norm, and they are happy to die at home with their loved ones holding their hands, with everyone gathered around them to say goodbye, and that would be considered a good death. And that's still happening in many regional countries in Asia. Right, where palliative care is not advanced, where home care is not so prevalent, not so accessible, the vast majority of people die in their own homes without medical support, without palliative care support. Right. So what has changed over the centuries is that medicines have come to a point whereby it seems that we have all sorts of manners to control the way we die, to control how death can be and how death can look like. Right. But I think that is the ultimate lesson in life to learn. When we confront diseases and death, we must learn how to make peace, how to let go. And it is a very precious opportunity to teach our children, our loved ones around, that, mommy or daddy, have learned to make peace with the fact that I have to leave. This is a fact in life. We treasure our time together, but when it's time, it's time. And I can do it very graciously. I can do it very peacefully. I can reconcile all the differences that I've amassed over the centuries, over the decades, sorry. I can go very peacefully. And that is a very beautiful thing as a legacy to teach our children and grandchildren. But if we were to opt for, a controlled death, sedated, sometimes it begs the question of whether are we escaping from something that we can't control, that we can't accept. That's a philosophical question. But of course, I'm not going to say that I'm going to let this patient suffer to the end just for him to have a taste of suffering, right? There needs to be a sweet balance of comfort, right? So that's one. The second point I want to make is that, patients sometimes wants to be deeply sedated because they fear that looming presence of death coming nearer and nearer to them. They fear needing to confront issues that they do not want to resolve, have no ability to resolve. For example, if someone hasn't been on a best relationship with the rest of the family, they refuse to come towards the end, and he's got all these anger and unresolved businesses, and he's just besieged by all these negative thoughts and emotions. He might want to be deeply sedated. In this situation, in a utopian state, would you prefer that healthcare professionals counsel you, provide you with comfort, offer you good therapy, art therapy, music therapy, pastoral care provider to help you make sense of your life and have a chance at letting go and making peace with the world? Or would you want to have the easy way out, be sedated deeply and then go into the night only to wake up in some other world with unresolved issues and you start all over again? So I think that's something that we need to deeply contemplate, right? But maybe as an ending remark to that very loaded question, while family members may request for us to keep our patients deeply sedated, we may not do so just because they insist on it. If the patient wants to be aware and alert, we'll help them keep alert and aware as much as possible. Right? If the family members want the patient to be as awake as possible, we may not see it as well. It is not a commercial contract just because you pay the hospital to do a certain thing, right? The doctors and the providers, the nurses needs to consider what is professionally acceptable, and then we would then weigh what we would consider the best interest of the patient in our minds as well.
That is a really interesting answer, and I have so many follow-up questions.
Mm-hmm.
However, in the interest of time, we have two more questions.
Sure. Mm-hmm.
One is, given Singapore's aging population, is Singapore adapting its policies to the increasing needs for palliative care?
Definitely. So, I think we quote this figure too often. Is it 2050 that 1 in 3 will be 65 years or older, or 2030, 1 in 4 will be 65 years and older. So that dependency support ratio is going to go really haywire. And you can just imagine walking along the street and 1 in 4 person would be a senior, right? And the truth is that with the advancement of therapeutics, be it cancer or organ failure, people are living much longer. And I would think that in my lifetime, cancer may become a chronic disease. For many cancers, maybe not all, but some of these cancers may become a chronic disease. And we are seeing that now. Some of our breast cancer patients, from the point of diagnosis, are living for decades. Right? I'm not talking about the stage 1, stage 2. I'm talking about stage 3, stage 4. Right? Yeah. So when we have a large population with a lot of chronic illnesses, right, that will impair their function to various degree, there will be a social problem. Right? A social problem in that you have got not so many children, professional caretakers to help support them to have meaningful and functional lives. Right? It becomes a societal problem because healthcare expenditure will markedly increase. The proportion of healthcare GDP will also increase extraordinarily, and that will slow down the whole societal progress and may affect all our lives, right? So Singapore's policies have shifted for many years already in preparation for this silver tsunami. But now we are not talking only about the silver tsunami. We are talking about the tsunami of chronic illnesses that may not kill a person so quickly, right? So how has that changed? The National Strategy of Palliative Care that's just done up 1 or 2 years ago is trying to look at a few domains. Number one, to increase access, to make sure that all patients who need palliative care can access palliative care, right? But that cannot be done so just by the number of trainees that we train to specialize in palliative care a year. There needs to be a cap of specialists, cost reasons and otherwise, right? So that's why we are trying to increase the interest of other disciplines, be it the general practitioners, the family medicine doctors, the cardiologists, and all the other specialists to take up fundamental palliative care knowledge so that they can take care of the basic palliative care needs in the patients that they see. Right? It makes sense because if, let's say, a lung doctor sees a patient for decades, it doesn't make sense that he will leave this patient to the care of the palliative care physician only in the last few days of life. It would be great if the rapport stays there and the same doctor takes care of the patients all the way till death. Right? It gives the patient's family comfort as well as seeing a familiar face, even when the patient is critically ill. Right? So one is to try to have more people learn how to deliver palliative care to increase access. Number two is to increase awareness of palliative care amongst the general public as well as healthcare professionals. Now, the third is not only to have people access palliative care, because that's pretty good already in Singapore. In my hospital, in my memory, those who die in our hospital, 1 in 3 cancer patients will have seen palliative care in the last year of life. For patients with non-cancer, it'd be about between 1 in 5 that will have seen palliative care in the last 1 year of life. That's pretty good, right? But we're not saying that we are good because we usually see them only in the last 1 week of life by average, right? So what we want to do is that we want to see our patients much earlier, months or years ahead, so that holistic approach of maintaining function, of relieving psychosocial distress, or preparing the patients and family for the inevitable functional decline and the eventual demise of the patient can be started way earlier with a much longer runway. So that's the access part of the thing. The second domain is, of course, in terms of quality, training specialists in a residency manner to make sure that the quality is delivered well, collaboration with other disciplines to come up with different services to match different needs. Right? So that's the other domain, right? So all these policies are in place. MOH has also, looked at this piece with a lot of passion and interest with our current minister, Minister Ong. So there is a pilot known as the Integrated Palliative Care Pilot, whereby Tan Tock Seng Hospital is collaborating with Park Hospice. The financial subventions has been changed, in this pilot service to allow our palliative care patients to have greater access to their MediSave and to their MediShield, so that actually when our patients do get transferred to the hospice, right, the out-of-pocket payout is actually very little for the vast majority of our patients, making palliative care very affordable. The public tends to have this notion that palliative care is expensive because they have the notion that there's a doctor there that holds your hand all the time and doctor costs money, but it's not true, right? It is heavily subvented by the government. Home care, for example, in Singapore is for free. Palliative home care is for free. Yeah. So I think all these policies are in place to make structural changes to make sure that palliative care is delivered to all who need it.
Yeah. I'm going to close off with a bit of a philosophical question once more. Not like we haven't been doing a lot of philosophy already.
Yes.
What do you find is most important for people at the end of their lives? What should I put on my bucket list before I get there?
Eat the burger.
I have.
Oh, no.
I think it probably shortened my life for about 5 years.
There are various surveys done locally examining what Singaporeans would be concerned about when they are imminently dying. The usual top 3 would be, I do not want to be a financial burden. I do not want to be a physical burden to my family members. And I want to die free of pain. That is the conventional answer that I will give you. And I think that will not change in the next few years to a decade, Yeah, but on a more personal front, is there a bucket list? No. The most important thing that we need to be aware of, to have a good death, is on a daily basis, be prepared to let go of everything that you have at any point in time. Right? Because death can occur at any time point, from a road traffic accident, or from a flower pot dropping off a HDB. Sudden deaths happen. You can have a stroke, acute bleed. You have a sudden diagnosis of a very aggressive cancer and die in 3 months. I know it sounds morbid, but the truth is, in a very cliched manner, everyone dies, right? So what is the type of patient, which group of patients dies most comfortably and most at peace? This would be the group of patients that have set every other affair in order. And if they haven't, they're at peace with it. And when they die, somehow or the other, they need less medications and less help from the team, and they pass away in a beautiful manner. There is a colleague of ours that we took care of, a very senior and esteemed colleague. I can't share much details because of confidentiality, but he has truly showed me how beautiful death can be. He's very open with his family about death and dying. He gave clear instructions. He was extremely peaceful, and it is very visible from the way he talks, the way he rests on his bed. The body posture is just so at ease. The way that he handles this very burdensome conversation with the rest of the family is so natural. And the family basically say, it's time to tell my loved one that he doesn't have much time left. I think you also need to share with the rest of the family. And I often had said, should I speak to the patient's wife separately? And the family said, no, I think he has prepared us so well. You can just come to the room in front of the patient and tell all of us, that he's dying. And there was minimal tears. Everyone was peaceful and at ease. And the dying process, of course, was minimal pain. And at the end of the day, of course, people were sad, but people can also have a chance to celebrate life, to celebrate what he has brought to this world, the legacy that he has left behind. And I feel on a personal front, we should celebrate the way in which he imparted this very important and valuable wisdom, which is the wisdom to cope with dying as an inevitability. And it can be done in the most gracious and peaceful manner. In the progress of medical science and all that, that's something that's got eroded really badly away. We think of death as something that's unnatural, as a problem that needs to be resolved and mitigated. It's not. Death is natural. The problem doesn't lie with death. The problem lies with how we look and confront death.
Moral of the story is always be ready to die.
Yeah.
Write that down, kids.
That's so interesting, because as you were saying that, I've always looked at death as something I will deal with and learn to deal with when it comes. And because of that, because I haven't accepted it, because I haven't dealt with it, there is fear in my heart of it because I'm anxious about it. Will I learn to cope with it? What will happen? And that's honestly, I'm having a bit of an existential crisis right now.
Interesting that you brought that up. That's an interesting Buddhist meditation called death contemplation. So the practitioner is supposed to think about death as a meditation object, and he must contemplate like this, I'm going to die at any point. I might die at the end of the next breath. I might die at the end of each meal. It sounds extremely morbid. I would think, why would any person ordained or unordained takes this practice, and how do you do this practice long term? And actually the practitioners would share that this particular practice actually brings joy. It brings a sense of release because it makes you look at life from a very different perspective. You don't hold on and clutch to things as if this is yours and mine, and you cannot, no people can intrude and violate. You look at life from a perspective that I try my best, I look out for my people, my family, I do good, I relieve suffering for people around. But whatever I do is impermanent, and when it's time, right? And that frees you from a lot of negative emotions. That frees you from a lot of issues with ego as well. And that makes you treasure your family on a day-to-day basis. I think that's something important to think about.
That's so true, because I read somewhere once that maybe it was a Buddhist philosophy, but the idea that one of the reasons why we feel pain is because we are not looking forward to the joy ending. And we know, this is going to end soon, I need to enjoy it, And you spend the whole time trying to prepare yourself when it will end, rather than just being like, this is what it is.
Yes.
So I think I might need to take the rest of the day off. I might call it a mental health day.
We're just going to be sitting at us like,
I have some affairs to get in order. I need to message some people. But that's, I think you've given me so much to think about. I don't have any more questions for now.
Yeah. Thank you so much for coming. This has been really fun. It's been amazing. Very
Fun?
Oh, thanks very much. It's
very reflective.
Yeah. I haven't shared some of these things I've shared to other audiences.
We are so grateful for your
You bring out the
openness.
best in everybody.
Oh yeah, we'll take credit for his wisdom. Thank you so much.
Thank you.
We know
Thank you
you're a
very
very
much.
busy person and you're welcome back anytime.
Great. Thank you. I enjoyed myself immensely as well. Yeah. Thank you for the invitation.
Welcome. Thank you.
Thanks for listening to our new podcast. Subscribe online and tune in every first of the month. In the meantime, listen to CBME and You and be savvy.